The Global Code, I would call it the Global Code from here onwards, is basically a code of conduct which was adopted in 2010 by the member states of the WHO after long and heated negotiations. I will not compare it with negotiations going on at this point in time, but it was long and it was heated, I know that. And the code was meant to guide member states in the governance of international recruitment, mobility, migration of health and care personnel, because even at that time in 2010, actually decades before that already, this was a phenomenon that was increasing. It's still increasing. And it seems to be increasing exponentially almost, I would say. And I would like to highlight three elements that are, I think, of particular importance for today, like this. Thank you. The Code recognizes the rights of individuals to migrate and it promotes the protection of all who work in the health and care sector, and particularly those who choose to migrate. The Code also stresses the need to strengthen health systems at both sides of the migration and mobility pathways, so both in the sending countries and in the receiving countries. And thirdly, it puts strong emphasis on the needs for stronger international and global investments and cooperation to strengthen health workforces worldwide.
Thank you, Corinne, and that's really a very good introduction to the Code for those who are familiar with the Code, but I am almost sure that you are here because you know the Code, you have experience with the Code, or you perhaps you want to learn more. And learning more is exactly why we come together here today on the goals of this event. We want to raise awareness about the Code while looking at the political and systemic obstacles that hinder the effective with our keynote speakers. We have Perpetual Ofori Ampofo with the Ghana Registered Nurses and Midwives Association. We have Dr. Balkis Abdelmoula of the World Medical Association and the Junior Doctors Network. And then we have Herbert Beck from the Verdi Trade Union in Germany and an affiliate of the PSI, both GRNMA and Verdi. Thank you.
So I come from Ghana, a West African state. And with our 2021 census, the population was quoted to be 31 million. Currently, it's estimated around 34 million. Generally, in Africa, the remuneration is not the best. And most of us are receiving less than $200 at the end of the month. And if you compare it to colleagues maybe in the US, in Canada, Australia, and other high-income countries, that's around 4,500 thereabout per month. So these then become the reasons why some of our colleagues will take the decision to also migrate. That's where the Code also comes to play. It becomes very important to guide these high-income earning countries to also take into consideration the health needs of the source countries and ensure that wherever we are moving or whenever we are moving health professionals, it doesn't affect health delivery in our own countries.
Now let's move on to Dr. Balkis Abdelmoula. She is a Tunisian family physician and based in Germany. So again, Dr. Balkis, within this overall framework of the WHO Code and its importance, can you share your personal experience, your migration journey from Tunisia, and now a family physician, you are based now in Germany?
So my journey, basically I didn't want to move out, so to start with. Back 6 years ago, I was here in Geneva attending WHA and I was advocating for doctors to stay in their countries. And, not to go against migration, of course, I am pro-migration and our organization is pro-migration. This is a human right for sure. But it is important to retain workforce, to support the need for the population for healthcare and to have good quality care for everyone and health for all, of course. So back to my journey. I finished med school in 2018, and then I had the crossroad to go into specialization. And in my country, there was a transformation of the system, and I couldn't get the specialty I wanted. So that's how the idea of migrating started. In Germany, once you get your degree recognized, you have the same status as any other German graduate who is in the system. So you get the same salary, you have the same working hours, everything is the same. Also, there is the flexibility of choosing what you want to train in. This is a very important thing, and this gave me like an alternative for what I couldn't achieve back home. So this flexibility, the postgraduate training system was very captivating, or was like the first, let's say, argument for the choice.
Moving over now to your country of migration, Germany, who is now beside you today, Mr. Herbert Beck, from the Verdi Trade Union Germany, the biggest trade union in Germany and in the world, as Herbert would claim, and an affiliate of Public Services International. Herbert has negotiated collective agreements at local, regional, and national level, and represented Verdi in the field of occupational safety and health at the Federal Ministry of Labor and Social Affairs. He himself is a registered nurse and held elected positions at Verdi, and currently a member of the PSI Executive Board.
Now we are facing a lack of 160,000, and it is predicted that in 2030 there will be a lack of 220,000 healthcare workers. In 2040, almost 500,000. And, the strategy was then creating bilateral agreements. Started with the Philippines and Tunisia and Serbia and Bosnia in 2013. So we are having now 11 years of experience in bilateral agreements.
We now open the fishbowl.
My name is Ariel Lanada. I am the president of the Filipino Nurses Association of United Kingdom. Thank you. I conducted a research study on the experiences of internationally educated nurses who migrated in the United Kingdom for 2 decades. So that's 2002 until 2022. Now, the significant findings in that research shows there is a big mismatch between the expectations of internationally educated nurses and their actual experiences when they arrive in the United Kingdom. Perhaps the international recruiters and the employers did not follow WHO Global Code.
My name is Alexander Nikov. I'm representing IOM, International Organization for Migration. My question is, I understand the bilateral agreements and I understand that the host countries are doing their best. In this case, we are sorting out a problem let's say the developed countries are facing with, but then on this account, we are depleting the health systems of the source countries. And we are leaving millions and millions of people in Ghana or in Philippines or in Macedonia, where I come from, Serbia, Bosnia, you mentioned all these countries. So what is going on with the health system that is actually depleted by providing the opportunity to migrate, which is absolutely insupportable. And it should be the regular pathways, within the regular pathways and all this, but then don't you think that maybe it should go both ways? That we should somehow oblige the country that is receiving the migrants to somehow invest in the health system from the sending country? I don't know, this is something that bothers me.
My name is Chidam Chiatela, Secretary General for Kenya Medical Practitioners, a pharmacist and dentist union. I think it's a question for almost each, but I'll take the shortest time. You say that in the global north, there is more of a older generation. That's the reason why there is more of migration of health workers from the global south. But we are seeing also that the countries in the global south have a lot of debts from the global north. In these government-to-government agreements, there are always provisions so that these debts that are owed can now be cancelled to these countries in the global south, because there's actual investment in the health workforce that migrates to the global north. That's one. Then to the doctor from Tunisia, I think we share experience, because in our country we are known for striking. We had a strike in 2017 for 100 days, and recently in the month of March to May we had a strike for 56 days. But our government has a plan or a strategy, whereby when we do strike for 100 days in 2017, then the government imported doctors from Cuba to Kenya. But these doctors were not allowed to join trade union, neither to our collective bargaining. On the paper, these doctors were being paid $10,000, but in their payroll monthly, they're getting less than $1,000. So we were seeing it like more of modern slavery between the government of Kenya and the government of Cuba. Again, in 2024, just last month, when we were on strike, we saw an agreement again with the government of the Kenyan government to the neighboring Ethiopian government, or the same. So how does the global code then apply to these countries?
Thank you very much. My name is Nina Bergman. I'm working for the Swedish Nurses and Midwives. I represent 114,000 members, and we are on strike right now. So support me, please. I'm so grateful for the presentations, and Perpetual especially. I appreciate when you talk about working conditions. I mean, it's different in the world, but something is like everywhere. That's the working conditions for nurses. Some time ago, well, for many years, you can say the health workforce in Sweden has been overused for a long, long time. And now we made a little survey for some time ago where we saw that 1/3 of our members are working part-time. Why? Because they cannot consolidate life and work. And that means that all these women working in healthcare get less pension, less pay, and so on, so on. So, you know, the story. But 1/3 is working part-time, but they're all working overtime. Everyone is working overtime. You never know when you can go home at the end of the day. So that's a big problem. And we also see that now 40% of our younger nurses are thinking about leaving the professions the years to come. Totally doing other things. After a long education, it's very sad. And society really needs them.
I want to pick on my colleague from Kenya. Code has been used as a restrictive mechanism by countries. Second, I'd like to pick up what my colleague from Sweden, helping health workers strike. And I'm doing that at the moment in the UK. I'm glad IOM spoke out. Sure, WHO will speak out. But the challenge we have is that code of practice on the international recruitment of health personnel should be actually international exchange of health personnel.
Interesting.
Because I've seen the UK use this concept of international recruitment of migrants to send them to Rwanda. And that's against all human rights. And the EU is doing the same thing for Tunisia. And a lot of migrants from Africa are being, what's happening in Tunisia and Libya is not acceptable. So we need to change our thinking. We are not like Philippines, who has a huge workforce in the ministry and others and can argue and good bilateral relations. So we need to change the thinking. And the last point, Medicus Mundi and People's Health Movement have health for all, but they have forgotten primary health care. They have not pushed WHO, and WHO has not delivered on primary health care.
So as an intern doctor, we're practically at a year where we have to practice post-graduation internship. Some people around the world do not get paid for this. Sometimes you get very small reimbursement. However, in terms of working conditions, it's extremely hard because at times we're asked to stay in the hospital for 1 full week. Sometimes we pull out 48, 36-hour shifts. But everything there talks about the health and care workforce, but this small group of internship or post-graduation internship that happens does not apply to that because under paper we're not actually part of the workforce, but we are integrated in the workforce and we are contributing to the workforce. So I'm wondering how would a code of practice can be considered into that? Thank you very much.
Thank you so much. My name is Howard Catherine from the International Council of Nurses. Congratulations to WEMOS PSI, WMA, for putting this really important event on. First, an observation, a more general observation. We came into this WHA with hearing that we're on track for the SDGs, health inequalities are widening. This issue is both symptomatic of and the result of bigger failures in the global health agenda. The failure to invest properly in health care workers, why we're off track so badly with the ambitions for global health. And then the recruitment that we're seeing and the widening inequalities and the harm of that as well. So there's something about positioning. I feel really worried that I'm not seeing a lot of action over the course of the last year, which makes us think, how do we get moving on this? How do we get moving on this? The code. I don't want to diss the code. I think it's really important. But I think we also need a reality check on this. Is it really doing its job? It's not. We're having this conversation because the code isn't addressing many of these issues that are coming up. I find it difficult to see how you can have a real, meaningful discussion about mutuality of the benefit, proportionality, without talking about the money. Mutual's not good enough to say mutuality is, look, there'll be some learning and sharing between our countries. Build the nursing school, invest in faculty, not just as a one-off, but a long-term. Say, look, I've looked at the health labour market plan for a particular country. I can see you're going to be short by 20,000. We as one country, or together as high-income countries, will come together and commit to a sustainable plan for 3 or 4 years to increase that capacity. There is real anger that's being generated, not just in the countries who are losing nurses, who talk about issues like modern slavery, who use the term, it feels like neo-colonialism. The nurses leaders in the countries who are doing the recruiting feel embarrassment and are publicly saying we do not support what's happening here. So there needs to be a much stronger, tougher initiatives, which there's an opportunity through this consultation to do. Last point, some people are talking about one of the solutions to all of this is to do more of the educate to export, because of the issues of unemployment, that we will educate more nurses in some countries to export. Could be helpful, but how does it address the long-term sustainability of the lack of healthcare workers in the countries who are losing? I was interested to hear the Philippines minister in this building on Monday talk about real concerns about retention and delivering healthcare to their people because of the third healthcare workers that they've lost. Thanks very much.
Thank you. Next, we have like 6 minutes left. And we also need to wrap up. I think Dr. Ruth has already given her perspective, which was very, very helpful for our discussion. And we could wrap up with Margaret sharing from their meeting today. But before that, yes, please, our brother. 1 minute.
Even 30 seconds. I'm Esther Yasuru from West Africa. We work in almost 35 countries in Africa. My question really to every one of us as we're discussing is how we can put the voice together. So we have this opportunity that is coming. How do we use it therefore to make sure that we make our voices heard? I think that's one thing, because we are doing this thing in silence. Sweden are standing up, Kenya is standing up, we hear the story, but we don't get together and put that one voice, and probably that's an assignment that we all need to have as we're moving to say, how do we come together and make that voice known so that we advance change. Yeah.
The code reporting is open for everyone. So as long as you're not a single person, You're from an entity, from a group of people, from an organization, everybody can report. There is the independent stakeholder reporting instrument. Please do share your experiences, the information, whatever ideas you have, and we will put that in the reporting and the review of the code. Low-income countries cannot compete at all with high-income countries when it comes to wages or working conditions. To address these drivers of migration, we need more investment from high-income countries to low-income countries. There's really no alternative to it. And again, I would like to conclude by requesting all of you to take part on this reporting. Everyone has a voice, and your voice will be heard. Thank you.
Opportunities, the challenges of migrating, those migratory journeys, the stories that are being told, we need to ensure that they influence the review of the code, that we are listening, putting health workers at the centre and listening to their experiences, the opportunities and the challenges. One of the areas that I picked up on when Baylis mentioned, I had to leave, but I can also change from the outside. So you can continue to advocate. One of the things SET works on is working with the diaspora health workers to support them to give back. We have many opportunities, we have many examples of diaspora engagement and the effectiveness of it in strengthening health systems. It also maintains those links between health workers who leave their countries with the country of origin. Perpetual mentioned about making, providing the mechanisms for people to come back. That's sometimes a barrier to having health workers give back and get involved in their health systems. I'm just focusing on health workers' perspectives because I think all the issues around the code have been mentioned. But one clear thing is, as many mentioned, is get involved in the reporting of the code, but also ensure that we're not just doing the report and it's on the shelf. We need to make sure that everybody knows the data that is coming through the code reporting and that we are using that to advocate and to ensure that we change things, whether we're inside the system or outside the system. We're all agents of change. Thank you very much.
You're going to thank the audience, I think, aren't you?
Thank you. Yes, we don't want to hold them any longer because we have to move on to the World Health Assembly. We've reflected so many views today, both practical experiences as well as suggestions, insights, policy recommendations. And with that, again, the key messages, it's about strengthening our health and care systems. Our workforce are the backbone of this. Migrant health and care workers have the same rights as any other, and all health and care workers deserve their human and labor rights respected and protected, but at the same time, there should be long-term sustainability and international cooperation on this issue of health workforce migration. That's a very, very short summary, and there are some more inputs that you have provided here today. And again, on behalf of the co-organizers of this event, we are really, really grateful for your presence here today. And let's continue to bring our voices heard. Let's continue to strengthen what we have at the WHO or WHO code and bring it also as well to other multilateral processes at the national level with our unions and organizations and partners and onwards to have, to achieve social justice and equity and justice and the human right to health.